This video presents the 2026 Guideline for the Early Management of Patients with Acute Ischemic Stroke from the American Heart Association and American Stroke Association. The 2026 Guideline covers adult and pediatric patients, from pre-hospital evaluation through acute treatment and early secondary prevention. It replaces the 2018 Guidelines and focuses on timely assessment, telemedicine, and emergency brain imaging. Top takeaways include the recommendation of mobile stroke units for faster treatment times. Tenecteplase is endorsed as a reasonable alternative to alteplase. Additionally, extended treatment windows are supported for unknown onset or wake-up strokes. New protocols support endovascular therapy for larger ischemic cores, defined as aspects 3 to 5. Intensive glucose control is not recommended. The target is 140 to 180 milligrams per deciliter. Specific recommendations for pediatric stroke care and blood pressure management post-EVT are also included. Recommendations are color-coded based on the strength of evidence. Class 1 is a strong recommendation, meaning the benefit far outweighs the risk. Class 3 indicates that the treatment or strategy is not recommended. Pre-hospital care is critical. Public education on warning signs is essential. EMS must use brief stroke assessment tools, and dispatchers must prioritize transport using these protocols. Pediatric tools have uncertain sensitivity in the field. The use of mobile stroke units over conventional EMS is a Class 1 recommendation where available. MSUs ensure the fastest achievable onset to treatment time and facilitate triage for endovascular therapy. EMS must pre-notify the receiving hospital. Transport should generally be to the closest appropriate facility. Bypassing a local center for a thrombectomy-capable center is reasonable if no coordinated transfer system exists. Standard imaging, non-contrast CT or MRI, must be performed within 25 minutes of arrival to exclude hemorrhage. CTA or CTP should be performed for suspected large vessel occlusion. Do not delay contrast imaging for serum creatinine levels. For pediatric patients, immediate MRI-MRA is reasonable to identify LVO and differentiate mimics. If MRI is not available quickly, CT-CTA is a reasonable alternative. Tenecteplase 0.25 milligrams per kilogram is now endorsed as a reasonable alternative to alteplase for IV thrombolysis. The concurrent use of adjuvant antithrombotics is not recommended. IV thrombolysis is not recommended for mild or non-disabling deficits. Dual antiplatelet therapy should be used instead. For pediatric reperfusion, alteplase may be considered within 4.5 hours for disabling deficits. Endovascular thrombectomy is effective for patients age 6 and up with large vessel occlusion. Endovascular thrombectomy is strongly recommended for anterior circulation LVO within 0 to 6 hours, with an NIHSS score of 6 or more and an aspect score of 6 to 10. The indication for EVT is expanded for selected patients with larger ischemic cores, aspects 3 to 5, within a 0 to 24-hour window. EVT in the extended window of 6 to 24 hours requires perfusion imaging or clinical core mismatch criteria. EVT is also recommended for posterior circulation basilar artery occlusion. Blood pressure management updates include avoiding aggressive lowering to less than 140 millimeters Hg immediately after successful EVT. Glucose control should target 140 to 180 milligrams per deciliter to prevent hypoglycemia. In-hospital management includes dual antiplatelet therapy for minor non-cardioembolic stroke. Dysphagia screening is essential, and early DOAC initiation is reasonable in selected cases. Complications like brain swelling and seizures must be managed. Quality care is supported by external certification, dedicated stroke units, and participation in registries. Systems must also address disparities in care delivery. The 2026 Guidelines introduce tenecteplase as an alternative thrombolytic and mobile stroke units as the preferred EMS option. EVT is expanded to include large cores, and specific pediatric protocols are now included. The primary reference for these guidelines is the 2026 Guideline for the Early Management of Patients with Acute Ischemic Stroke, published in Stroke. Time is brain. Systems of care save lives.